I guess I'm probably just gonna wait for her to tell me that it's good. Is it working? Yeah, okay. Amazing. I'm gonna use the wireless mic.
Do you want to move your? No, you won't be able to move your computer. I was gonna say, do you want to set your computer in the middle of that? But
1 second.
that's fine.
Oh. Okay.
Ooh. She's not up there. Now she is.
Okay. Is it showing my screen still?
Oh, you know what? Let me.
I am not showing my screen. I am glad that I checked. All right, guys, thank you so much for coming, even though it's cold out. I know that probably was not the most fun. But we wanted to start, of course, with our upcoming events like we always do. So this Sunday, there is a shift meeting at Duncan from 4 to 5 with Grace. And then Tuesday, we have our equine hospital rounds. The signups for that came out with the last email, so you guys should know by now if you got a spot for that, and that's 5 to 7, and there's 2 groups. Like there was 3 groups last time. It'll be run very similarly. On Thursday from 5:30 to 7:30, we have our winter banquet. So signups for that also went out in the email. If you guys are interested in coming and you haven't filled out the interest poll yet, you can still sign up. So feel free to do that. And then we have one more project that Alex is going to talk about.
Oh. Okay, yeah. So this is kind of exciting. This is something Paige and I talked about at the very beginning when we were doing our vet school applications. So for anyone that has applied this cycle, we kind of want to make like a vet school application survival guide. Basically just a lot of things we wish we would have known when we started, or things that we didn't realize we were going to hit as an issue until we actually hit them, to kind of give out to the general body as a whole for advice for like 1st through 4th years, all of it. So if you applied this cycle and you are interested in helping out with that, it's going to be more of a winter break project. You can come talk to one of us or just email me. My email is up on there. And we would love to have your help, and you will get an additional point for helping out. So just reach out if you're interested in that. And then I also wanted to throw in a quick note that next semester, I'm thinking ahead pretty far, but our meetings are not going to be in here. They're going to be in Plum Hall, room 220 over on CFAS campus. So we'll have more instructions about like how to get over there. If you're not familiar, we'll work all that out. I promise it'll be as smooth as we can make it. But just so we're all kind of on the same page, our meetings, this is our last meeting in this room. Yeah, so that's it for announcements. And with that, I'm going to go ahead and introduce Dr. Sturman over here. So she is a soft tissue surgeon at the Ohio State University Vet Hospital. She has years of experience, and she's going to be showing us some really awesome case studies. So.
I think the switch just, okay.
Maybe click. There we go. Click here. All right. Sorry, guys, I'm a Dell person and this is a Mac. So you're going to have to bear with me just a little bit. And if you ultimately can't hear me, I will switch the microphone, but I do tend to talk a little bit loud. So today I'm going to talk to you guys about some interesting cases that I've seen throughout my time as a resident and a faculty on clinics. And part of this is going to be a little bit interactive. So there's no wrong answers. I'm not looking for you guys to diagnose problems, but we're going to have a little bit of a discussion. And then at the end, if you guys have any questions, or during this, if you have any questions, raise your hand and I'm happy to stay around later and chat with you guys. So just a little bit about me. So I actually was in your seats a few short years ago. So I did undergrad here at Ohio State and was actively involved in the pre-vet club, and then stayed and did my vet school training here as well. When I graduated vet school from here in 2015, I made my way down south and stayed at A&M for about 5 years, where I did a rotating internship, surgical internship, and stayed for my residency. And when I finished that in the middle of a pandemic, I ended up at Purdue for a couple of years before coming here. So if you guys have any questions, I've also helped with admissions at Ohio State, Purdue, and A&M. So I'm pretty into what you guys would need to do to get into vet school as well. So we're going to start off with one of my first cases here at Ohio State as a new faculty for them. And Jackson is a 12-year-old male castrated Yorkie. He presented as a big dog, little dog. So that's what BDLD means. So you'll see that written around a lot in the hospital. And so that means a big dog attacked a little dog. His family flew in from Vermont to stay with a sister because of a death in the family. And the pit bull decided that Jackson was actually a little chew toy. So he presented for a head wound. So when they first come in, the things that are important is to kind of get a good, quick physical exam, make sure that they're otherwise stable. But Jackson's problem was pretty apparent. So this is, as soon as he came in, we assessed him, made sure that he wasn't going to die, and we heavily sedated him and found this. So what do you guys think is going on, or what is missing from this dog, or what do you guys see on the screen? Again, there's no right or wrong answers. This is just to get you guys involved a little bit. So what do you guys see is missing? Let's start there. Yeah. His ear is missing. His ear is completely gone. The owners actually brought it into us and they said, can you reattach it? And we're like, no, we don't do that. No reason for him to have it. We take ears off all the time. So Jackson did not end up with his ear back, but his ear is definitely missing. Can you guys, yes, my pointer, this is gonna be great. So his ear should live right here. So this is his eyes, nose, mouth coming down here, and this is where his ear should be. What else can we see that we probably don't really want to be seeing that's a little scary when this walks into your ER? So it's not his brain, but it is his skull. So this is his bone right here. This is just a little bit of muscle that didn't get torn away. And then the rest of this white shiny stuff right here and here, that is all bone. So what kind of things do you think you guys need to do when you see this? When this comes in right away, do you think this is something that we can go ahead and stitch him back together and keep him maybe one night overnight and send him home? No, nope, lots of head shakes. So when we saw this, we were like, ooh, he's in for a lot. And this is a 12-year-old Yorkie, remember? So these owners were like, yes, we live from Vermont, but we're here, we're committed, we're in it to win it. So the next thing that we did with him, is we took him to surgery about a day after he presented. So he came in overnight and we decided, let's just get a bandage on his head and then we'll take him to surgery the next day because there's no reason to rush into this at, 10 p.m. at night. So the following day we took him to surgery, and what you can see here is this is a little like stylet that's actually inside his inner ear. So right where that's sticking into, this is his inner ear. Do you guys all see this like tube-like structure right here? Anybody have any ideas what important anatomic structure that could be? I will tell you that it's not a blood vessel. So what would be another important structure that's not a blood vessel? It is the facial nerve, exactly right. So the facial nerve runs right below the ear. And so when we do this surgery planned, it's called a total ear canal ablation. When we plan to do it, we watch for the facial nerve, we protect the facial nerve so that it doesn't get damaged, because the facial nerve, one of its jobs is to let you blink. Well, this little structure should continue into this area. So unfortunately for poor little Jackson here, his facial nerve was cut in half. We figured that when he presented, he was unable to blink. So this was not a surprise finding. We expected to find it. We didn't actually expect to see it just like sitting there in our way, just like flopping around, but we did. And so that's what it looks like here. So then what we did is we actually went in and we removed this little cuff of tissue. That's all of the ear canal that was left behind. We scooped out all of the junk from inside of his ear because we don't want to have to close over this and then him to get an abscess from any infection or any tissue left inside the ear. So he got a total ear canal ablation with a bulla osteotomy. It's called a tikaboo. And we do this routinely. We actually did one yesterday, planned on a dog, kept all of its skin, all of its that stuff. But this exact surgery that this dog did to its housemate, we have done before. So once we did all that, we then cleaned up all of the kind of dead tissue that was around there. So if you notice on this picture, you can kind of see these don't really look like bite rip marks. These are from us cutting away dead tissue. And so that's what we've done, debrided everything that wasn't healthy. Do you have a question? Mm-hmm. Correct. Nope, just the right eye. So this one controls just this side. There's an identical on the other side. Yep. So his other side was blinking well. Unfortunately, his other side during his hospital stay ended up getting an ulcer, but this eye never did. The eye that could blink, that was down all the time and all of our wound care and everything, it ended up with an ulcer that we had to treat, but he's completely healed. You'll see at the end, doing great. But it did develop an ulcer. This side did not develop an ulcer. So at this point in time, we have a few options. And so some of those options include local wound management, where we just do bandage changes every single day. There's another option, though, that we ended up going with that we liked a little better, and that's called a wound vacuum. So this is the wound vac right here that you guys can see. So what we basically did is we debrided all that dead tissue, and then we put this spongy black thing on it. And that is silver impregnated. So the benefit to that is silver is antimicrobial. So we took an antimicrobial sponge, basically, stuck it onto where that whole wound was. We ended up doing a quick little surgical procedure to his eyelid on that side called a tarsorrhaphy. So we basically sutured his eyelid shut so that we could put stickiness all over that side of his face. So that's what you see. All of this is all sticky drape-like material because we have to create an airtight seal. And then we stick this little, there's a tiny needle in the center here with this little suction cone. And what happens is it goes to a little backpack that's constantly pulling and adding suction to it. So it's called a wound vacuum system. We use them in humans as well, the exact same machines actually. And so by doing this wound vac system, we were able to take care of infection. We were able to also cause granulation tissue to form. So this is his head again, looks very, very different than before, but all of this nice pink, reddish, happy tissue that looks way prettier on my screen than your screen. Sorry about that. We were able to get that all to grow up, and you need that to make a healthy, happy wound bed. So we took care of infection, we caused all this nice granulation tissue to come in, and we actually caused contraction or shrinkage of our wound by having this vacuum on. And he wore this vacuum for about 7 days. Because when he came in was a Sunday night, and then Monday, and then we got him through the weekend and the week with this on. And then we took him back to surgery, and this picture down here is a Monday picture. So we took him down to general anesthesia on Monday, took our wound vacuum off, and this is what we saw. So what do you guys think? Do you think this is pretty enough that it can get closed, or do you think he needs some more time to heal? Raise your hand if you think he's ready to get closed and to heal. Raise your hand if you think he needs more time in the wound vac again. Okay, so I'm going to disagree with most of you, and I'm going to say it's time to close him. So we actually took him to surgery that day, and we said after 7 days with very minimal growth, we completely closed him down. So this is him after his first procedure. So we were able, these are all, he's got deep sutures that you can't see, and then these little blue guys are all sutures that are on his skin. We did put some clear white ones down on this side coming down his face, but we were able to get everything to go together. Yeah. So part of the vac, the main job that we used it for is for the granulation tissue to give us a healthy bed, and then the contraction. So what it did is it actually caused the skin to pull together to shrink the wound down. So we didn't actually have to do many techniques in order to get the skin to completely cover this. So what's really great about him is that we were able to just bring the skin together without doing anything. So our vacuum system caused the skin to stretch so much by being suctioned that whole time with constant pressure pulling on it, that it brought it all together, brought all of the edges of it together, so that all we had to do was place some deep sutures that just helped walk it a little bit more, but we didn't have to do anything else. If our vacuum had not done as good of a job as it did, what we would have done is we would have actually taken the skin from his neck and advanced it, doing what we call a skin flap. So we would do an advancement flap of that to come up and close him. But because our vacuum did such a great job, his skin wanted to live right next to each other without us having to do any work. Yep. So what we did is for him, we did this first surgery. He healed great. About 3 days later, right here where these incisions kind of come together, and we couldn't help that. We couldn't help making this T-like shape. So anytime you make a T or a Y, anything that has lines coming together, it's a point of high tension. And it's a point that if you add movement, like let's say someone opening and closing an eye to put drops in there, that movement along with a kind of a V triangle T shape causes a little bit of it to fail. So he actually had a second surgery about 5 days after this one, where we just had to reclose down this corner right here. But that was not a big problem for him or a big deal. He got 3 more sutures added in about 5 days later. But surprisingly enough, when he left our hospital 3.5 weeks after being here, his eye was moving a little bit, his skin was moving a little bit on its own. We don't know how, because we definitely saw his facial nerve severed. Our ophthalmology team also admitted that they saw him do like a small little blink, so definitely not a normal blink, but a small little movement of the eye. We have absolutely positively no idea how he is able to do that. So he is still on eye drops. He has now a dry eye condition in that because his eye is not fully normal. So his owners put eye drops in this eye probably about 2 to 3 times a day. But dogs also have third eyelids that come up. So it's not a death sentence if your dog can't blink. Ideally, we want them to. If they can't, we do add some extra moisture to them, but that third eyelid will also help them a lot and keep them from getting any types of ulcerations or anything like that. So this is him about 2 more weeks after he left us. So he went home just in time for Halloween. He was Frankenstein for Halloween. And then this was the picture they sent us of him having his best life in Vermont, being a super happy dog. They're incredibly happy because of how we had to pull and move his skin around. You can definitely see better on this screen, but you can definitely see how he's got a different color hair up here than he does down here. And that's because with that shrinkage, we ended up not us doing it, but that vacuum pulled up some of his neck fur, pulled down some of his head fur. So he's got 2 different colors growing in there. But he looks as cute as ever, and the owners are really happy. Nope. He was on basically no pain meds. We gave him NSAIDs. So he was on carprofen because that made us feel better. But with the wound vacuum on, he let us touch him, pick him up. He went out for walks. He was running around in his kennel. We would just hold him for fun. He was eating, drinking, completely happy, and on no sedation, no pain meds, nothing. I mean, on NSAIDs, but not because we thought that the vacuum was painful. Just we figured if your ear gets ripped off, you might have some degree of pain going on. Humans will say that wound vacuums are very painful because they're constantly like sucking at you. And so in humans, they actually do an intermittent vacuum system. So what that means is as though it's on you 24/7, it's only sucking like 2 hours, then off for 2, on for 2, off for 2. We left his on the entire time. So for 7 days, constant sucking of all of that area, but he was a trooper. He had no issues with it. He loved it. His owners were wonderful. And so he stayed with us for about 3.5 weeks before hopping on a plane back to Vermont. Mm-hmm. Nope, we didn't touch it. We saw it and we said, you're the facial nerve. We're not touching you. What you can't appreciate from that picture so much is that it had that stump, and then where it should have been into was like 3 little like where branches. And so it was definitely severed from those 3 branches. So I have no idea how he can partially blink at all right now. But so this was one of the first cases that I got when I came here. So we get a lot of really exciting things that come through. Any other questions about him really quick? All right. So our next case is Billy. So Billy is you're going to know, a lot of these dogs are all male, and I don't know why. And I don't think I put any cats into here. I'm not a big cat person, so I mainly stuck to dogs. So Billy is a 7-year-old male castrated coon dog that presented for vomiting. So what would be some thoughts if an animal's presenting to you for vomiting? And we'll give a giveaway. I'm a surgeon, so probably a surgical based disease. What would be some of the things going through your head of, what kind of cases is this going to be? Yeah, perfect. So a foreign body. What else? Anything else that could cause vomiting? Okay, so an obstruction. Yeah, so a torsion, so either a mesenteric torsion or a colonic torsion. So for Billy, he came in, got some radiographs and an ultrasound done. What do you guys, I know haven't probably seen a lot, but we can take the guess that this is an ultrasound and this is radiographs. So when we're looking at imaging, things that we're looking for is if you're vomiting, what do we see, right? So this is the giveaway signal for what this disease is. We'll talk about our radiographs first. So when I'm looking at radiographs, I look from the head all the way to the butt. And I start that way. I start top and then I work down doing that pattern. So we know he's here for vomiting, but we should always check everything. His spine looks really nice and straight. I don't see anything weird going on there. Don't see anything weird going on with his pelvis. Don't see anything weird going on with his legs. He's a boy dog. He has an os penis. All of that's normal. These are his ribs. Nothing exciting there. So then we can move away from our bony structure and say, okay, I'm worried about vomiting, so I'm most likely worried about the GI tract, but before I worry and focus on that, let me make sure that the rest of the abdomen looks like what I expect. So if I look up here, here's one kidney, his other kidney is going to be up here. I don't see it great, but that's not a huge issue. Down here is his spleen, also not worried about that. This other little kind of triangle coming down here that comes up this way, that's all liver. And then way back here, there should be a bladder, but I don't really see one. So reasons that I might not see a bladder is it's not there, which doesn't really make sense for him. But in a dog that presents for vomiting, why might they not have a visible bladder on radiographs? What might they be doing that's causing them to not have a bladder? They still have it in their body, we just can't see it well because it's not full of fluid. Perfect. So he's pretty dehydrated and he's not letting any of that fluid really go anywhere else. He's bringing it all up because he's vomiting so much. So he's pretty dehydrated and I don't really see a good appreciable bladder because he's so dehydrated. So then the next things I look for is to try to give me an idea of, do I see an obvious foreign body? Do I see a corn cob? Do I see piece of metal? Do I see, I don't know, I had a little Christmas mouse the other day in a dog, and you could actually, like, now that I took it out of the dog, when I go back and like inspect the radiographs, I'm like, oh, you can actually see like the body and the little ears. But in him, I don't really see any of those things. So I don't see an obvious foreign body sticking out. Then I look and I say, well, can I see loops of intestine or are they all cloudy? And I'm like, I can definitely see loops of intestine coming around here and all of this stuff. So I have good visualization, and that tells me that there's not free fluid in the abdomen, because free fluid in the abdomen would make me very, very worried that we're septic, that something's ruptured inside. And that would mean I don't care what these images look like, we're going straight to emergency surgery. But he doesn't have that. He also doesn't have free air in his abdomen. So free air would also mean he's ruptured, and we would look for that up here. But what you can see here is this, like, I don't know, R, backwards R shaped thing right here. That's his stomach, and it's full of air. And so that tells me that fluid isn't really getting through. He's vomiting it out. He's probably painful and breathing in and taking in a lot of air. We call that aerophasic. And so for me, I say, okay, his stomach is nice and empty because I can see that there's tons of air inside of it, not tons of fluid, nothing in there. So I'm probably not dealing with a gastric or a stomach-based problem. So in this vomiting dog, I then know it has to be his intestines. So what I'm going to do is I'm going to look for 2 different populations of small intestine. And what that means is it means really, really wide ones and really, really thin ones. Because what that's going to mean is that there's something stopping the fluid from getting in. So the really, really thin ones are going to be after the obstruction. The really, really fat ones are going to be before the obstruction because they're blocking everything from getting through. So they're going to dilate or fill with fluid or air. And so I don't know how well you can appreciate there, but right here, there's really, really wide ones. Down here, there's really, really thin ones. And so when you see that, but you don't have a direct cause, you have to decide if this is a surgical problem, he has an actual obstruction, or does he just have really bad GI enteritis or inflammatory bowel-like system? So we took him for an ultrasound. So this is his ultrasound, and this is really the only image that I care about in his ultrasound. And this is what we call a target sign, because it looks like an outer rim of a circle with a circle in the middle. So like you guys all know, target has like the big and then the little circle in the middle. So this is a target sign, and it's classic of one single type of disease. Does anybody know what it is? Bonus question. All right, so it's for an intussusception. So a target sign is where you have a loop of intestine and another loop goes inside. So you get a loop inside a loop, which makes 2 circles, gives you the target sign. So as soon as we saw this, we said he has an intussusception. So basically one of his loops of intestine was eating his other loop of intestine. So what that looks like is this. So what you can see here, a small loop, big loop, this loop is being eaten by the other loop. So how do we prove that this is actually what's happening? Well, to prove it, which I don't always do, but for picture purposes, one of my friends did this. So they took an instrument and they pushed it in as far as it went to prove that it stopped. And it stopped where that loop was being twisted in. So what we do is we actually basically take the spots down here and we squeeze in a motion like this while someone's pulling over here so that we can actually pull it out while we're squeezing. So one person's pulling, one person's squeezing, so that you're basically pushing it out from the loop that it's somehow ingested it. So all of the loops are still closed, but basically what it managed to do is slide in. Right here is our mesentery. This is where our blood vessels live for our intestines. This is our anti-mesenteric border up here. So that's where there's no blood vessels. Sorry, I keep going too high and too low. So what happens is this somehow gets in between here, and it basically telescopes in itself because they're pretty mobile. So our intestines move around the body. It's what makes it so easy for them to allow different things to get past. So large meals or socks or other foreign bodies they shouldn't eat because they do move, but sometimes they get stuck. And when they get stuck, they telescope. And so that's what's happening here. So when that happens, we squeeze them and push them. And so this is a zoomed up picture of us squeezing it out. And so there is a little bit of tearing of the outside of the intestines there, but all things considered, it doesn't look that bad. And so once we get it all out, most people then look for a cause. So sometimes they'll have a foreign body that allowed one to telescope into the other, and then we have to remove it. Sometimes it's for cancer. Sometimes we find a mass that's usually some type of cancerous mass, and we need to remove that. But the most common cause of this is actually idiopathic. As in, we have no idea. As in, we feel, we search, we can't find anything. There's no foreign body, there's no cancer, there's no good reason. They don't have any GI parasites. We can't find anything at all in them. And they just do this for fun. And so when that happens, there's nothing that we can do to prevent it from happening again. But they typically don't do it again after they've done it once. So this is a little intussusception, and this dog recovered just great and did fine. It's typically a dog disease. I have seen it in one cat during my residency, and that cat actually belonged to like our head of our large animal department. So that was a little terrifying because we didn't find a cause in that cat. And we're like, well, this is not a cat disease, but your cat has this and there's no cause. So we're a little worried, but that cat is doing great so far. Any questions about intussusceptions? Except that the loops, the lumens are not open. So the intestines aren't exposed to the insides of each other. They somehow find a way to push just the outer coatings of them to eat the other loop. It sounds weird. If you see it, then that makes more sense. I truly don't understand how they actually physically get this to happen, but they're very soft, very pliable, and they can expand to quite a size that it basically allows them while still closed to eat each other. Correct. Nothing can pass. And so that's why they get really, really sick, because nothing can get past that, because that intussuscepted loop, so the loop that's been eaten, is so squished that nothing can get through that. And then the loop that's eaten it is now so squished because it's eaten a loop of intestines that nothing can get past that either. So it basically has, in essence, two obstructions, but it can't get past the first obstruction. So we don't see any evidence in the GI tract of the second one. And so that's why we follow our GI tract when we do our GI ultrasounds. We start at the stomach, we follow through the duodenum, follow it through the jejunum, the ileum, into the colon. But if at any time we lose track of it, we try to find it again. And if we see that target sign, we automatically know has to be an intussusception. Yeah. So this dog, he actually was sent home the next day. So abdominal surgeries, depending on what they are, the most painful part is when you actually push on the abdominal wall. So when we put in a Balfour or some type of retractor and push that open, that's the absolute most painful part. So for this dog, the surgery itself wasn't that painful because we didn't have to really push on his abdominal walls. We were able to pop this out, and then it took us a few minutes to like squish it apart. Once we did that, we searched all the intestines, made sure we didn't find any other problems, closed his abdomen, and he did great under anesthesia that day. Woke up, did great overnight, was actually eating for us about midnight that night. So surgery finished for him around 3-ish p.m. in the afternoon. We started feeding him around midnight. He ate dinner, ate breakfast in the morning, was trying to run around his kennel, thinking life was great. So we added more sedation onto him, and then sent him home that afternoon. So he was feeling great, recovered really fast, did not stay with us for a long time. It depends on the cause. So if you can find a cause, then no. So if you find, say, cancer or a foreign body, or they have an intestinal parasite, you find something that you can treat, they'll probably never have it again unless they get said thing back. If you have a dog who's idiopathic, who gets it for no known reason, yes, they could do it again, but in my experience, I've never had a repeat offender. So no dog that I've ever cut for this has had it again. And a paper actually came out looking at, I think, about 100 of these cases across a few institutions, and none of them were repeat caused. So what I would say is, if it happens once, it's probably a fluke thing that happened to your dog, and hopefully will never happen again.
Is there anything else you guys do after you're pulling apart?
So there's papers that say that you could do something called interplication. And so what that means is you suture the different intestines to each other so that they can't actually eat themselves again, but they're now like kind of set up in a stepwise pattern. The other option is you could do an RNA, resection anastomosis, so remove the section that was actually eaten, because maybe there was something wrong with it that you couldn't recognize by palpating and seeing, and even if it looked normal, maybe there's something wrong, or you could do nothing. And that paper I talked about looked at doing all of those options and found that doing the RNA is about the same as doing nothing, which is about the same as doing interplication. But there's complications associated with doing the two surgical procedures versus less complications of doing nothing additional to what you've already done. So from my training and my experiences, if I don't find a cause, I just let it all be. And I don't take it out unless I'm worried about the health of that intestine, then I'll remove it. Otherwise, I don't do anything in these guys. Uh-huh. Yep. Yep, everything then just passes through like normal. And they act like a completely unobstructed normal dog. It depends on the dog, and it depends on where it is, and it depends on the cause. It also depends on how observant you are as an owner. So I've had some owners that are like, well, Fluffy barely ate dinner. I'm bringing Fluffy into the vet. And you're like, well, sometimes I don't want to eat dinner, right? I don't necessarily go to the doctor or the ER because I didn't want to eat dinner. But they're like, nope, nope, nope. Like, something's wrong with Fluffy. And 9 times out of 10, they're actually right, which is kind of frustrating because you're like, darn it. Versus some owners, the dogs are literally flat out, not moving, not doing anything, haven't eaten for 3 days. And they're like, yeah, I guess there might be something wrong. Sure. Or they wait till it's Sunday after church and the kids come over and they're like, why is Fluffy like not moving? Oh, Fluffy's been like that for a while. We should probably take Fluffy in. So some owners are on that end, some owners are on the other end. I'm an owner that my dog is like a happy vomiter. So he'll vomit every like few weeks and do one vomit, but run around and be eating and drinking. So for me, if he didn't eat dinner one night or he vomited one night, I would not take him in and get him checked out. But he would have to do that for me quite a few times in a day to raise my level of suspicion. So it really just depends. This specific dog was vomiting for 3 days and didn't eat for 3 days before they brought him in to see us. I might have brought my dog in a little sooner if we were, because he doesn't usually vomit for 3 days in a row, but it's kind of hard to gauge. All right, we're going to go to a female dog. Ooh, this is going to be a fun one. I remember this case. So this is Winnie. She is a 10-year-old female spayed Labrador that comes into you for a presentation of difficulty breathing. So we're going to say she has a surgical-based problem because there's lots of non-surgical-based difficulty breathing problems. So what can you guys think of might be something that would be a surgery-based one? Yeah, so collapsed lung, that would be a great idea. I did not put one of those in this presentation, but that would be a fantastic idea. So for her, because this one's gonna be a little harder, she has a lot of free fluid in her chest. And so she has, these aren't her radiographs because her radiographs don't come labeled like this beautifully, but here what you guys can see is from what they've labeled, lung is these shapes, and then all around it is fluid. And so what she had is she actually had chylous fluid, or fluid that looks like milk, sitting and floating in and all around her chest. And so when we find that, what happens is they come in for difficulty breathing. We take a radiograph, we say, oh no, you've got fluid in your chest. and we actually stick a needle in there and we pull a lot of the fluid out. And the reason we pull it out is by taking that fluid out, we'll give you room for your lungs to expand. And then we'll have fluid that we can look at under a microscope and figure out what's going on. So her fluid was a milky white chylous fluid. We ran some tests on it to prove to us that it was chyle. And then once we knew what it was, we have to do some imaging so that as a surgeon, I can figure out how to help her. And so what that means is from this picture, what you can see here is this white thing up here. This is our cisterna chyli. It's where all of the lymph fluid flows through your body up at the top by your spine, actually comes through the top of your spine, through your chest, and it empties out up in your neck through something called the thoracic duct. And humans have this as well. In humans, they actually can address a lot of this surgically up in the neck. My father's a human surgeon that addresses it up there. So when he heard about this case, he's like, "Ooh, this is special." And I was like, "No, this is what I do. I do it in the chest. He does it up here." And so for her, what we did is our CT was down, so she got a radiograph. So do you guys see this line up here? That is going to be contrast that was placed inside one of her lymph nodes in her leg. We wait a few minutes until we know it's moved enough, and we take some radiographs and we can actually see it going into her chest, and that is her thoracic duct in her chest. And the reason we do this, a CT is way, way better. It allows me to see actually where all of the little branches are of this duct system. But by getting this imaging, I can see exactly where I need to go into her chest to occlude it and stop it. So that's what we do. We go open their chest and we actually search for that thoracic duct. So down here, right here, this big white thing, that's actually the azygos vein. Then right here above that, we have our aorta. And then up beyond that, this little black, dark bluey thing, that is going to be our thoracic duct. The reason it's blue is intraoperatively, we'll actually place dye inside the abdomen. We'll open up the abdomen, get a little bit of the intestines. There's lots of lymph nodes that live there, and we'll inject the lymph nodes there with a little bit of blue dye because the lymph nodes drain into the lymph system, which is our thoracic duct system. So we inject dye into our lymph nodes that travels through our lymph into our thoracic duct, makes our thoracic duct nice and blue so that we can find it, dissect it out, and we actually throw sutures around it and then cut it. And the reason that we're doing that is we're separating it and we're preventing it from leaking. And so that's why we do our CT, so that we can see how many branches it has to make sure that we get all of those branches so that we can stop all of the leaking. The number one most common cause for this, can you guys guess? Any guesses? No wrong answers. Idiopathic. So we have no idea. That is the number one most common cause. In humans, it's usually traumatic. So usually they get into a hit by car or they get whiplash or something like that from a car accident. They get this and it resolves on their own. In our patients, they don't get injured as frequently as this disease occurs. So most of the time it's idiopathic. Otherwise, cancer can be a cause for it, but 9 times out of 10, we never figure out what's happened and why it's gotten this. So we go in and we occlude this area, we separate and open up this area, but then we do one more surgical procedure for them. So we actually place this device inside them. So this is called a pleuroport. And what that means is that this is a port that is palpable on the outside of the skin. And this part of the device, this tubing, actually goes inside the chest. And so what that does is it gives us a drain that's living inside the chest that's connected to this port system. The port system is attached to the muscle and the sub-Q, and then we put the skin over on top of it. And so it allows us to drain the chest very easily without us having to stick a needle into the actual thorax all the time. We just stick it through the skin into this little port. We don't have to stick it all the way into the chest. The benefit of this is that if our surgeries don't work, and unfortunately in idiopathic dogs, it doesn't work in about 20 to 40% of cases. So realistically, we only have success in 60 to 80%. So it's a very frustrating disease process. So we place these ports to allow for much, much easier removal of the fluid without us having to keep poking into the ribs all the time. So this is called a pleuroport that we place inside of there. So, all right. So we'll talk about Spencer really quickly. So Spencer is a 6-year-old male castrated Dalmatian that comes into you for a history of difficulty urinating. So what do you think is the most common cause of a male dog not being able to fully urinate? Yeah, perfect. So bladder stones, it's going to be your most common cause. And in Spencer, that's exactly right. So these are not Spencer's radiographs, but these are radiographs that show you a nice representation. So Spencer's radiographs don't show the stones because with his breed of dog has a type of stone that only shows up on ultrasound. His do not show up on radiographs. But to give you a good idea of what it is, these are some radiographs with some stones inside the bladder here. And this dog has a few little stones inside its kidney as well. The reason why in male dogs it's such a problem is the urethra is really, really long. And then they have this os penis. So this right here is a normal bone. That's the os penis, and it causes the urethra to taper. And when that happens, the stones usually can't get past. So just like in this picture, these are all stones indicated by the arrows, and they're all stuck inside that urethra. So when that happens, the first thing we have to do is pass a urinary catheter to push all of those stones back in the bladder, because it's much, much easier to do a surgery into the bladder and remove the stones from there than it is to cut into the urethra. So that's step one, is to push all the stones back into the bladder, and then we can remove it from there. And so once we do that, then we do a cystotomy. So this is, again, not that Dalmatian, but Dalmatian's a good case in the name that I had. So what we do here is we find our bladder. So this is our bladder right here. We place a stay suture up at the top of the bladder to help give us a handle to hold on to. We make a stab incision into the bladder, and we scoop out all of the fun stones. And this is a fun job. Lots of stones, lots of scooping, lots of flushing back and forth. And our goal surgically is to remove as many of these as possible, because if they go back into that bladder, they're going to cause them to not be able to urinate again. Some dogs get this disease over and over and over and over again, where they have these issues where they keep making stones. So in Dalmatians, they actually have a defect in their genome that causes them to create urate stones. And so we have to change their diet to keep them from doing this and to actually supplement what they're missing in order to help them. Other like small breed little fluffy dogs, they also tend to make and get in too much calcium for what their body needs. So they make a lot of calcium-based stones. So in animals that have had this happen all the time, like our little Dalmatian friend, we actually have to do another surgery called a scrotal urethrostomy in dogs. And what that basically means is we go in and we make them a new hole that they can urinate out of. And it's in front of that penis bone. So it's in front of the os penis bone. And the reason that we do this is this area of the urethra is really, really wide. And so even wider stones that can make into the urethra can usually pass out there. And so it keeps the dogs from getting obstructed. So what we do, and so you can kind of see, this is an intraoperative picture, this is a post-op recovered picture, and this is a how to do it step-by-step picture. We basically go right in their scrotum, so where their testicles are. We take the testicles off, go into the scrotum right there. We feel for the urethra, we bring it up to the skin, we cut a hole in it. We make a nice, long, wide incision. So that's what's happening here. This is a urinary catheter. This line right here is the edge of your mucosa of your urethra. This line right here is the edge of your urinary urethral mucosa. We suture the mucosa to the end. And so that's what you can see right here. So we've sutured that mucosa to here. And so we give them a new, nice big hole that they can urinate out of. This works for tons of them. However, sometimes like today, we get really fun phone calls. So on Monday, I took a phone call from a veterinarian who was doing a cystotomy on a dog. And when he went in, he realized that the vet that had unblocked the dog had actually taken that urinary catheter and put it through and through the abdomen, in through the bladder. So the dog had a urinary abdomen bladder, or uroabdomen. And that means there was free urine floating around in the abdomen because he'd ruptured the bladder. So he calls me because the bladder won't close appropriately. And so we talked to him and we're like, well, you can do some tricks to help get it to close. But we really, really, really recommend that you place a urinary catheter post-operatively into this bladder, because it's going to be very, very helpful to keep the bladder nice and small so that the bladder can heal really well. And the bladder bleeds really, really well, so it heals really, really well. Well, today, and if this is working, stick with me. All right. Today I get a phone call from that same vet. We're trying. So this dog has an os penis here. Some of you already know the answers because I gave it away. But for those of you that don't, this dog was supposed to have a urinary catheter in. The owners took the dog home with a urinary catheter in. And they woke up this morning, and what do you think they found? Anyone, you can just scream it out. So the urinary catheter, only half of it was out of the dog. So we get a phone call today that there's a urinary catheter stuck in the urethra. So do you guys see this little like stone looking tip right there? That's actually the tip of the urinary catheter inside the bladder. And you can follow it going up through here, around here. And do you guys see this line right here? That's urinary catheter. So it shouldn't be there. So this dog has a urethral foreign body, which no one that's currently working at Ohio State today has ever seen before. No faculty, myself, our medicine team, our anesthesia team. We've never seen this. So this vet who talked to me on Monday calls me today and says, hey, what do I do with this? And I'm like, ooh, you don't do anything. You send that to us. And the reason is that this dog already has a compromised bladder. So we really don't want to operate into that again. But we can't just leave him with this foreign body of a catheter sitting in his abdomen. So here we go. So this is what we found today. So I don't know how well you guys can appreciate it, but this is us right here pulling out the urinary catheter. This is the remaining portion of the urinary catheter. No, go back. So we got it all out. We put our scope back inside and we saw this right here. So unfortunately, this vet had left inside some stones. So they're right here. We pushed them back into the bladder because we're like, ooh, they should go back in there. Hopefully he'll pee them out later. And then we looked inside the bladder, and this is actually the vet's cystotomy incision right here. So we can see that and how that's healing. The dog woke up, and all of a sudden, the next thing we know, he urinates and pees out his 3 stones that we had seen when we scoped him. So these are his little urinary stones right here. This is an image of it zoomed in on our, because our camera is magnifying. And then here is the catheter that was inside the dog that it shouldn't be. This is our action shot of us pulling it out. And then this is his cystotomy incision. So sometimes scary bad things can happen, but luckily nowadays between the camera systems that we have to use in surgery and the camera systems our medicine team has, we can remove a lot of things minimally invasive without having to go back to surgery. So this was a really cool one today where we didn't get to do the fun part of the surgery, but we did get to go in and like grab the catheter out of the urethra, and no one's seen a urethral foreign body before. So it was kind of a really fun thing because he couldn't pee around this. So he was actually being now occluded by his urinary catheter that was supposed to be helping him. So it was a fun, sad day for all of us. So, all right, we're going to go to another female dog. So this is Ellie. She is a 5-year-old female spayed Bernese mountain dog that presented for lethargy, an ADR, so just not doing right. Ain't doing right is what ADR stands for, but we just say ADR. Makes it sound a little bit more proper English. 2 days after a previous foreign body surgery. So what would be some of the top concerns you have for this dog that's suddenly not doing well a few days after it's had surgery in its abdomen for a different reason? What would be some of the most important things that you're thinking about? Yeah, so which sutures? Mm-hmm. Yeah, so either the ones that we sutured the abdomen with, or this dog had a foreign body that got removed, so maybe the ones that are actually on our intestine. So for her, this is what we saw when she came in. So unfortunately, she had a dehiscence of her inside the abdomen on the intestines that had opened up and leaked. And so that leaked into the abdomen, which then caused lots of fluid to be sitting into the abdomen. And our sutures on the abdomen wall are not meant to withstand tons of things against them. They're meant to withstand the intestines and the organs, but when you put liters and liters of fluid dumped into this dog's abdomen from this now open into its intestines, so she's not vomiting because it's all just filling her abdomen with all the fluid instead of it coming out or going out either end, it's just filling. So it's not meant to withstand all of that pressure. So what then happens is it starts to leak through. So the owners noticed she wasn't feeling well. They didn't really notice that when she stood up, they're like, yeah, it was always wet. We just figured it was urine. Well, nope, it was not. So this is what happens on these slides, things that we're looking for. So we know this is a septic abdomen because here you can see a normal white blood cell with lots of little bacteria inside of it. So normal white blood cell, that dot, those little dots are bacteria. Normal white blood cell with no bacteria. Normal white blood cell, the darker purples are all little bacteria bulbs. So when you see that, it's a septic abdomen, and then you worry about what's going on with that. So for her, she went back to surgery. This is what we found. So we found that there was a nice big hole inside the spot that we were at. And so we had to go in and do an RNA. So we actually had to remove that section of intestine because it was really, really dead and unhappy. So I think we can all appreciate that this is not normal. This hole should not be there. It should be nice and close together. The reason that it looks darker red, and here you can see these like splotchy little like really dark red spots, it's from peritonitis. So having all of that infected icky fluid sitting on there causes the edges and the serosa, the outer sides of all of the organs, to get really inflamed and unhappy and causes peritonitis. So that's what you're seeing through all of this. So we went in, we removed this section of intestines, flushed her abdomen really, really, really well, put her on really aggressive antibiotics, kept her in the hospital. She needed to stay with us for about 4.5 days, and then we sent her home and she's doing great. And so these guys can get really, really sick really fast. And unfortunately, no matter what the cause is, a septic abdomen has about a 50-50 chance of survival if they make it off the OR table. If they make it off the table, 50-50 chance of survival. So these are not wonderful prognosis. It's not a great thing for your pet to have if they have it. But if you can catch it early and treat them fast, then it's got a better prognosis.
Was it like a leakage, or was it like something that if you once you like later down you notice it's leaking slower?
So when we got her in with the history, we sedated her and then opened it. So we got a massive amount of leakage, and we already knew what we were probably dealing with just by our experience of seeing a huge abdomen with fluid draining down, her being sick and lethargic. She was also febrile on presentation, tachycardic. So high heart rate, high temperature, high respiratory rate, painful abdomen full of fluid. The only option for that is going to be most likely a septic abdomen. So we kind of knew before touching her what was wrong with her. And so we already had a plan to take her straight to surgery and explore her. But for us, we had a little bit of leakage. And then when we just gently pushed on that area, it kind of like started more fire hose spraying everywhere. To me, it didn't smell that bad. I am used to it. For me, I think Pseudomonas smells the worst. It smells like rotten, stinky feet odor. And so I can usually pick up on Pseudomonas. The other ones I don't think smells all that bad. So for me, it smelled like dog and not really a horrible infection. Probably not. They would not have noticed the smell. They should have noticed the milky white, foamy, stringy discharge underneath her that does not look like urine. White, disgusting, pus-looking stuff and urine look very different. So they should have recognized that. But again, it's very hard, right? Some owners are like, oh my God, there's a drop of blood in the urine. Let's call the vet. Other owners are like, oh yeah, it's been peeing blood for 2 weeks. And now we're in because my son thinks it's a problem. So your owners will come in with a variety of different things going on. All right. Oh, I do have a cat for you. So this is Bella. She's a 3-year-old female spayed domestic short hair. And she was one of the first cases I ever had when I was a brand new out of my residency, first year faculty at Purdue. And so my resident called me and said, hey, you're never going to believe what I found. And I was like, what do you mean what you found? She's like, well, this is in the hospital. And she sends me pictures. I get these 3 pictures from her. And I'm like, oh, is it alive? And she's like, yeah, of course it's alive. They want to go to surgery. And I'm like, great, wonderful. I have no idea what the heck is going on. So what do you guys see going on here? Yeah, there's an arrow literally through the whole cat, right? So what we can appreciate on these radiographs, which I should have looked at more closely before taking this cat to surgery, it would have brought my blood pressure down a whole lot. But you can see the arrow here coming all the way this way, coming this, and look at that, it fractured the leg because the arrow is literally straight through the femur bone and fractured it. And so you see this here, you can look at the imaging from this way and you see it comes through and it's straight through the femur. So in my head, I should have been like, well, I know it's in the chest, I know it's in the abdomen, I know it's in the leg, but what important structures did it miss or did it hit? And in my head, I was like, oh my God, it must have gone through the heart because I had one of these that went through the heart and that was traumatic for my life. But if you would notice, the heart's way up here, nowhere near this arrow. So I don't have any intraoperative pictures because we took this cat to surgery at 3 a.m. and my blood pressure and heart rate and my adrenals were all going like 100 million miles a minute. But this cat is one of the luckiest cats I've ever seen. Why? Because basically all the damage this did was cause this multiple fracture of the femur in the chest. It didn't hit any lungs. It didn't hit any structures, any major vessels. It literally went in just at the like most caudal portion of the lung, was like 1 centimeter, the thorax was 1 centimeter in the chest and into the diaphragm. So it missed everything of importance in the lung, in the heart, in the blood vessel. So all I had to do was just close the skin and close the diaphragm. Super easy, not a problem. In the abdomen, it went through and through the colon, and that's it. It missed the liver, it missed the stomach, it missed the spleen, it missed all the important vessels, it missed everything except for 1 loop of colon. And it did it right at that anti-mesenteric border, so the border that has no blood vessels. So I literally just had to close it. It was the best time of our lives. And then it exited right out here through the caudal body wall. And it was like magic. There's nothing that lived there. So it missed everything. So I had a super easy surgery at 2 a.m. where all I had to do was close a few little circles in this cat. And then my orthopedic team got it a day and a half later to put together this leg in some fun manner. They put an interlocking nail inside the cat. So they basically took something that's a long stick with little skewers at the end and reconstructed the bone to fit to that long stick. And so this cat could have been way, way worse. It missed everything. Missed everything of importance except for a little bit of colon, but honestly, probably one of the most terrifying things that I've ever seen, but had a really, really good outcome. The neighbor shot it. To be determined. We don't know that, but I have the arrow in my office in case for some reason anyone ever needed it. Just because they never called me because they're suing their neighbors for this. And so I have it just in case it goes to court to be like, yep, here's in fact the arrow. But we don't know the reason behind it. It's not like it's like I've seen this. The other one I had was a husky that was shot through and through, and it kind of looked wolf-like, if you will, because it's like grayish silver husky. So the person claimed, oh, it was a wolf. You knew your neighbor had a husky. An arrow is not like a long-range firing device, like not these kind of arrows. They're not like, you know, bow and arrows I'm hunting with. And even if they are, they're not long-range firing devices. So, but that one, the arrow is actually going like this because it was through the heart. This one was not going like this because it was not through the heart. Mm-hmm. Yeah, so these arrows have metal running through them, and I didn't want it to shatter or splinter. So this end up here is not sharp and pointy. This end down here that's not visualized is sharp and pointy, but this end has these little like feather things to it. And so I didn't want to take the feather things through any of the cavities. So what we did is we actually backed the sharp pointy bit out. So we started in the leg and we backed it out, made sure that we weren't getting any femoral artery hemorrhaging or any hemorrhaging to the leg. It missed all of the important leg arteries, all the important leg nerves, all of that, missed all of it. So we got it throughout that, then brought it into the abdomen, and we brought it like up through the abdomen. We held up the loop of colon it was in, brought it out of that, sutured our colon shut, followed it up to the body wall through the diaphragm, pulled it into the chest, sutured that chest wall, the diaphragm shut, pulled it out through the chest, sutured the chest wall shut, and then it was out of cat. So we backed it out that way. So we did like a sequential surgery to get it out. So there always is. So we cultured the chest and we cultured the abdomen and we cultured the leg just because the leg was going to get a surgery to put a permanent implant in. So we wanted to make sure there was no infection there that was different than anywhere else. We cultured the abdomen because it went through the colon. And then we cultured the chest because we're like, well, even though it went in first before hitting the colon, we had to pull it from intestines out. And so we were like, ooh. We also got up a little sterile swabber and swabbed it before we actually went through the chest. I don't think that did anything, but it made me feel great at like 3 a.m. So I was like, oh my God, it's going to die. So it made me feel fantastic, but I don't think it did anything. So we cultured all three and actually nothing grew anything. So Again, incredibly lucky cat. We put it on a 2-week course of antibiotics anyways, because made me feel better. I slept better at night knowing it was on antibiotics, but did fantastic. Went home about a week after this, because after its second surgery, it just didn't want to eat and was just like really painful, which makes sense because like all of the pain and all of the inflammation was kind of hitting it at that point. And so it took it about a week to recover in the hospital, but went home and is doing great. You would have no idea it was shot by an arrow. All right. And I know we're over time. I can keep going or I can stop. It's up to you guys. I don't want to hold you.
No, yeah. If anyone like needs to head out, you're more than welcome. We're not gonna, but yeah, if you want to like have any others that you're super into, but you guys are like really free about.
So this is another fun chest case. This is Tiny. He's a 4-month-old female, or she is a 4-month-old Yorkie that presented for weird heartbeats. So these were her radiographs. It is classic for a disease called a PDA, or a persistent ductus arteriosus. So basically when you are in utero, you are not breathing for yourselves, your lungs not working. So your blood does not need to go to your lungs, right? You're getting all of your oxygenated blood from mom. And so you have this little vessel that allows you to go from one side of the heart to the other side of the heart and skip the lungs like you normally would. So in real life, we go heart, lungs, heart. In utero life, we go heart, weird vessel, heart. So in these dogs, where the vessel does not close down, we get this persistent ductus arteriosus, where the ductus arteriosus is that vessel. And so we get these large globoid looking hearts with these weird little bumps right here, because what's happening is more blood is going through this vessel than should be, because there should be no blood going through this. So when we look at this anatomy, our esophagus runs up here. This is going to be our phrenic nerve. This is our vagus nerve, and our aorta runs right here. So that extra little vessel lives right here, which that is this little vessel. So these are from surgery books, but this is actually our little Yorkie friend. So what we do is we dissect with the heart still beating, open heart surgery, basically. Heart right here still beating. We make a little hole in front of this really big vessel and a little hole behind this big vessel. We actually go underneath these big bleeding vessels that if they bleed, the patient will die in less than a minute, because they're typically small little creatures. They don't have a lot of blood volume in them. So if we rupture this really big vessel, they're in trouble. So we just pass our instrument underneath, pass our suture. So this is silk suture. So it's silk just like you would think of for clothing. Silkworms, they make this. It stays around for a long time. And the reason we use silk is that it has no memory to it. So what that means is, if you see how straight these are, even though it was wrapped up in a circle inside the packaging, it's completely straight because the suture itself does not remember the shapes it's been in. So we can tie it nice and tight. It stays around for life, and it causes a really good fibrosis of what's going on. So we tie it around nice and tight right here, causes that big vessel to shrink down, which stops blood from going through that vessel, which now means the blood goes through heart, lungs, heart, which means these patients actually can go on to live a completely normal life. And we can reverse all of their cardiac disease. So their hearts that get really, really, really big because too much blood is being pumped around it too quickly because it's missing all the lungs, we actually can make their hearts back to being normal, small hearts. The cool thing with these guys is that when you palpate them, so when you feel, you can actually feel this heart murmur. And in your hand, it feels like it's vibrating. So it feels like the heart is doing a thrill or just vibrating in your hands. And when you listen with a stethoscope, it sounds like a washing machine. So it's just a constant swishing motion. You can't even really hear heartbeats because it's just so much blood so quickly moving through this vessel in usually such small animals that all you hear is and then you can feel it thrilling underneath. So this is a PDA. We actually have one of these going to surgery with us tomorrow. So yeah. And then Ziggy, I think, is one of my last cases. So Ziggy is an 11-year-old male castrated mixed breed dog that presented actually to our optho team for a bulging eye. And so what they did is they did a CT, and they found that there was this weird mass coming up right around the eyeball, all through here. And so something that lives in that area is one of our salivary glands. It's our zygomatic salivary gland. So if you guys all feel right below your eyes, you'll actually feel there's a bone right there. And that's your zygomatic bone. So right underneath it lives your zygomatic sialocele or salivary gland. We're not very creative with our names. So this dog's eye was actually bulging out of its head because of this salivary tissue right here that was pushing it out. So the eyes here, this was growing so big, pushing it out, that this dog's eye was bulging out of its head. And the CT showed us that it was some kind of huge mass. And so the most likely cause in this dog would be some type of cancer, because though it could be a non-cancerous process, really cancer is the only thing that's going to grow this big, this fast in this area. And so to get to it, we actually have to cut that bone you guys were feeling on your face. We slice it in half so that we can fillet it open, so that we can get all the tissue out from inside of it. And then we suture the bone back to itself. So we actually poke holes in the bone and pass suture between those holes to grab it and pull it back together. So this is Ziggy. This is pre-op. You guys can see that the eye is bulging out. This is also pre-shave. And then this is Ziggy post-op, where you can see that, yes, his third eyelid is up, but it's much smaller. This bulge swelling is actually gone, versus here it's now out and bulged. And so this is not him, but this is a better picture because my intraoperative ones didn't actually scan over nicely into the computer. So this is that bone that we felt on ourselves. So this is your zygomatic arch, that zygomatic bone. This is where the salivary tissue lives right there. So because this is a normal dog, it looks normal. But in him, it basically exploded out. As soon as we cut that bone open, it kind of went, bloop, and we're like, oh, it's there. This is great. And so we scooped it all out, got all of it out. We have to be really careful because, as you can see from this picture, there's some really important nerves and veins that live in that area that we don't want to disrupt because they go to the rest of the face. And so then we sutured these bones back together, and Ziggy went on to do great. It was a parotid or a zygomatic adenocarcinoma. So we followed him up with some radiation because I couldn't remove half of his face, right? So with cancer, our goal is to take it all out and then get around it and take 2 to 3 centimeters of everything it could touch. Well, that would be his eye. That would be these muscles. That would be part of his mouth, part of his nose, things that works the rest of that. And so that's not really doable. Most owners don't appreciate, a half facectomy. So he got radiation therapy after this, and he's doing great. These are really rare cancers. We don't see a lot of zygomatic cancer. And so that was rare for him to have, but he did fantastic with this procedure. Oh, okay. I think this might be my last one. So Oliver, 11-year-old male castrated German Shepherd, presented for non-productive vomiting. Anybody have any ideas what this might be? This is one of the most common diseases that we see surgically as an emergency. Correct. Not a foreign body, but something is obstructing. Does this help you guys at all? What? Yeah, so he has bloat. Bloat's other name is called a GDV, or a gastric dilatation volvulus. So what you can see on these radiographs is that he has a gigantic stomach. Then what the stomach's done is it's filled up with air, and then it's flipped on itself. And so when the stomach fills up with air and flips on itself, it basically is preventing anything from coming up. So he feels like he needs to vomit. His stomach is huge and full and distended, and he wants to vomit. But because it's actually rotated, nothing can come out. And so that's what these radiographs look like. They're a Popeye's hat, or Popeye arm, Smurf hat, some type of double compartmentalization. So a compartment down here, a compartment up here. And so with these, they're surgical emergencies. The only way to fix them is to go into surgery. So medically, what we do while we wait on our anesthesia team, wait on the surgeon, is we actually take a needle and we poke it into the stomach. And so we do that so that we can get the air out of the stomach to make it nice and small, so that way, hopefully they feel less sick. Hopefully we can take all the pressure off of those big vessels, like our caudal vena cava, our aorta, all of those things that are getting squished by this huge stomach. And then we take them to surgery. So in surgery, what we see is this. So up here, this is our stomach, and someone is poking it with a needle to help make it nice and small, because sometimes they're so big that you can't actually do anything with them because they're just so big, huge sacs that we can't bring them out of the abdomen and flip them around. So we make it smaller. Once we make it smaller, we grab it, and we basically do a motion like a bicycle kick. So we reach in, we grab whatever is floating up, we take our left hand, and we basically punch down while we pull with our right hand, and we do a bicycle circle. And that allows us to flip and derotate our stomach in the appropriate manner. Once we do that, we feel up for our esophagus to make sure that the esophagus is a nice straight tube. We feel down our duodenum, make sure that's a nice straight tube, and then we check the rest of the abdomen to see if we can find any causes for this. But I bet you guys can't guess the #1 cause of a GDV. Anyone? Idiopathic, right? So like almost everything that I've said today, right? It's all idiopathic. So the most likely reason this happens is idiopathic. It is more common in our older dogs because there's ligaments that hold our stomachs up. And just like us, as we get older, things sag. Well, the same thing happens to our pets. And so as they get older, the ligaments in their abdomen sag and they don't hold the stomach into place as well. So as it gets bigger, there's more strain and stress on them. It allows them to flip. The surgery to correct for this, once you've derotated it, is you do actually have to tap this one. So what we do is we make an incision inside of our stomach, make an incision on our abdomen wall. So this is making an incision on the stomach, incision abdomen wall, making sure we like where they go together, and then we suture them together. And it's called a gastropexy. You can do this as an elective procedure. So if you guys own any large breed or deep chested dogs, oftentimes you'll hear your vet talk about doing an elective gastropexy. It's elective because they have not had a GDV. They're not on my table at 2 a.m. for an emergency. So we have time and we get to choose to do this versus when they present as a GDV, there's no longer a choice. They have to get this surgical procedure. So it doesn't matter if you're a girl or a boy dog. It doesn't matter if you're 1-year-old or 10-year-old, if you are a large breed, deep chested dog, so Great Danes, Irish Wolfhounds, some Labradors that are really deep chested, we recommend it in all of them. I've actually seen GDV in both a Dachshund and a Corgi. Makes no sense because they're not large breed, but if you think about it, they're really deep chested small breed dogs. So I do in certain dogs recommend it in those as well, especially if an owner asks for it. It is doing an elective gastropexy is a very easy procedure. It does require you to be in the abdomen. We can do these minimally invasive, so I can do them through just 3 small 1 centimeter incisions and do it all with a camera and equipment that way. And we do that here as well. We do them fully minimally invasive here. And so you can do that as an elective procedure. In face of being a GDV, you have to do it fully open abdomen because you have to derotate the stomach. But these are gastropexies. So a GDV is one of the most common surgical emergencies that we see. Yes. If it is a surgical bloat, it can bloat where it doesn't flip. So it can just bloat. And that's called a gastric dilatation. The volvulus is when it flips. So it can bloat from just fluid and air, or it can get a food bloat where it's just so full of food that it bloats. But most of the time it'll do the volvulus and actually twist on itself. Yep, you can definitely try that. A lot of veterinarians don't go that route and they prefer just putting a needle in it instead because the dogs are not very cooperative. And in order to put a tube down its throat, you're going to have to heavily sedate it. And most of the time they don't want to heavily sedate them. And so because of that, we just usually poke it with a needle to let the air out instead of doing the tube. Other questions about GDVs? The stomach and the air comes out. Is it going to cause problems by letting a bunch of air get into the... Nope. So air can be in the abdomen, not a problem. Air can be in the stomach, not a problem. Because the stomachs are so big, and when we think about physics and pressure, everything's going to want to rush out, then not a lot's going to rush in. And so when we poke it in, we actually keep pushing inwards. And the reason we're pushing inwards is if you have a balloon and you stick a needle in it, as the balloon gets smaller, it's going to fall off the end of our needle. So we actually keep sticking in further and pushing in so that way it stays inside it as it's falling down so we can get as much air out as possible. But we stick needles into the abdomen all the time to look for cancer. So we'll poke masses, we'll poke fluid, we'll poke tons of things. So needles into the abdomen are not a problem. All right, any questions? This was not my patient, but this was a friend's patient. So this is a foreign body where I think you guys can all figure out where the foreign body is. This dog ate a lot of some type of brick looking things. They're not bricks, but they're like foam bricks or something like that. I think it was like foam bedding that was in its kennel. But any questions? Things I can answer for you guys?